He'll be talking about digital subtraction myelography. He's an associate professor here at University of Toronto, and he's been pioneering CSF work here in Canada. So, Dr. Farb.
Do you need that, or do I need that? Thanks very much. Thanks for having me speak here today, and we'll get to it. I'm going to talk about digital subtraction myelography. I think I just have an advance, so hopefully this works. The videos will be started in the back. So it may be a little disjointed, but we'll see what we can do. We're not really going to, over the next 15 to 20 minutes, tell you how to do digital subtraction myelography. There's a lot of publications out there that'll help you with that. A lot of you are already doing them, which is great. Let's do more. I'm going to just show you what we've learned and areas that, things that I think would help you know about, some tips and tricks, problem areas that we've gotten over, some things that we're still dealing with, and we'll get started. I have no disclosures other than that I'm on the advisory board for CSF Leaks Canada. So what's the trick?
The green button.
I'm doing that. Give it a moment. I have a laptop I can hook up if I need to. Okay, that's better. I'd like to thank my contributors and collaborators who have put together a great program at Toronto Western. It keeps growing, and you'll hear more about that. I'm going to talk about how what we do at digital subtraction myelography follows from what we learn about these leaks from the MR results, as you've just heard Dr. Callan go through. How we do our myelograms is starts with basically setup and positioning. We'll talk about type 1s and type 2s, tips and tricks, etc. This is how we started out over 10 years ago after I went down to Cedars-Sinai to see how Wouter, Shavink, and Marcel Meyer were doing myelograms. Came back and I tried to reproduce it. Our machines were good, but not as good. We couldn't do a direct frontal lateral view. We couldn't get in our biplane angio, neuroangio suite and actually do it. So we quickly kind of figured out a way to do it in our center. The system requirements to do these things, obviously you need a very good angio suite that gives you, a high rate of pictures for fast imaging and high quality, high spatial imaging. You need a large intensifier. Obviously, you want to be able to image a large portion of the spine. You need to be able to table tilt and to move it. Sponges, bolsters, wedges. You need a proper kit with all kinds of needles and markers and rulers, etc. You'll get all those things eventually figured out. We now do it with another room, and we only use one single plane. We have the largest intensifier in that plane, and we do our patients awake with just local anesthetic. What type of DSM do you do? There's really two types of DSMs, one looking for one species of leak and the other one looking for the second type. And the MR tells you which ones you're going to try to do. So if we have a patient with a epidural collection or a spinal longitudinal epidural collection, I call a SLEC, they're SLEC positive, that is one type of leak. It is due to a dural tear. It's either ventral or along the side, and it's mechanical. The second type of leak, the second species of this is the SLEC negative patient, brain positive, and that's a CSF to venous fistula. That's essentially what you're looking for. It's a non-physiologic siphoning of CSF. It takes it away from the perispinal space, and you look for it differently. These are basically type 1 and type 2 leaks, a ventral tear. 80% of them are going to be ventral tears. 20% to 30% are going to be the lateral type 2 tear. You look for it by capturing that moment in time on a digital subtraction myelogram when the contrast gets out of the thecal sac and into the epidural space. The type 3 leak, or the spinal CSF to venous fistula, is in a lateral decubitus position. You're looking for it, and you're looking for basically the sequence or the video of the images that come up when you're looking for the leak lateral to the thecal sac, getting out in between the disc spaces. So this is a patient in prone position. 80% of these patients who have or are SLEC positive are going to be a ventral leak. So we start with a ventral or a prone position. You can see the patients are positioned adequately so you can count the vertebra. If you see the leak, you want to be able to count it and tell the surgeon exactly where it is. And you can see here that there's a leak somewhere in the upper T-spine. Can't point to it, so it's kind of obvious if you watch the video. You'll be able to see this at home. Thank you. And you can't see it on the screen? Yeah. There it is, right there. And, oh, I didn't want to go that fast. Can we back up one? Thanks. So, sounds like something Michelle Obama would say, start high, be ready to go low. So this patient's positioned for our digital subtraction myelogram in a prone position. That's C1, so I can count, and I'm ready to do some counting. Contrast comes up, and I don't see it where I thought I might see it high. Very commonly, these leaks are high. But as you look more inferiorly, you can see the contrast is already coming out, filling the spinal longitudinal extradural collection and falling by gravity against the vertebral bodies. So you move the, can you hit, is there a video on that? Or maybe I'll just go to the next one. There we go. You take a look lower down, you just fluoro down and go take a look, and there's the needle at L23, and here's where the leak is. So start high, but be ready to go low. You'll capture it. It's not a problem. That's just the actual run. Watch your cheater is another thing my fellows will hear me say, because the cheater is the contrast that we inject to make sure that we're in the subarachnoid space and that we're not in a subdural space, because that will ruin your injection. And you can see that quickly you inject and it falls anteriorly. You know you're in the subarachnoid space. In the AP view, in a patient who's prone, you inject and you'll see it just puff out and very quickly fall away. So watch the cheater. This is just fluoroscopy. You'll see the video. It starts by the contrast material falling down through the patient who's in a prone position with a nice table tilt, set up nicely on the sponges, and you get the contrast comes down, and you can follow it up to the cervical spine. So you watch the cheater. And if you watch it, watch what it's doing. Here's the contrast in the thecal sac. And just with that 1 cc of cheater, you can see it falling out into the ventral SLEC. And it'll happen right here. And that was with a half to 1 cc of contrast material, and the exam's over. You found the leak and you're done. So use that cheater and keep an eye on it. It also tells you if you've positioned the patient properly. If not, you can put in an extra sponge. There's just the next slide just shows the full injection, and you don't really see it any better now that you know where it is. So this is a patient that's not going to be as simple. This is a male with a ventral or large ventral SLEC, and we suspect has a ventral leak. You get into this problem with the shoulders, and a lot of people who do DSMs realize this is a problem area. Firing through the shoulders, trying to get the photons to go through there and define the anatomy is difficult. Even though the patient's in a nice prone position and perpendicular to the floor, and you've got the contrast is going to layer on the ventral aspect of the thecal sac, you can table tilt and you can tilt the image intensifier to try to angle through all of the bony structures, but you'll still have some problems. Sorry, guys. You'll still have some problems actually seeing the contrast get out through the hole into the epidural space. So here's that patient. Here's the myelogram. Here's the digital subtraction part of it, or the subtracted myelogram. You see the contrast coming up, and I can't exactly tell where the contrast is getting out. Is it getting out? I'll check lower down and make sure that it's not coming out inferiorly. This is just the run. If you start the video, I think. No video. So in the non-subtracted imaging, I still can't tell where it's coming out, but I'm convinced it's coming out somewhere in this area. And this is a very common problem if you do digital subtraction myelography, particularly at the cranial-cervical junction, at the cervical-thoracic junction, trying to find those leaks. You can check lower down and make sure, no, I didn't miss it. It's not coming out lower down in the lumbar region. But you can convince yourself that it is out in the upper thoracic region. That's in filling the longitudinal extradural collection there. So that's where we go to our post-myelogram CT scan. We always do a CT scan after the digital subtraction myelograms. We always do them within about 20 minutes. And this is not dynamic. This is just the patient staying in prone position going to CT. And you can see at the T1-2 level, we have a spur or a small spicule that's very commonly associated with a ventral type of leak, a type 1 leak. Problem is he also had a spicule, even a better spicule at the T2-3 level. So right in that area where I'm trying to figure out where he has the leak, and I know it's probably in that area from the myelogram, I can't discern it. So this is a problem solver, and you're going to hear this from Dr. Callan as well probably. We do a dynamic CT myelogram in this patient rather than just repeating the DSM and trying to fire through the shoulders. This is really helpful. You know exactly where it's going to be in the upper thoracic region. You set up for that. You don't have to spin up and down the entire spine. You just inject the contrast and wait for it to come out, and then bang, you hit it with your CT, and you can see that it's clearly coming out at the T1-2 level. What about the type 2s? Again, 20% of them are going to be, 20% of those patients with the SLEX are going to be a type 2 leak. Not a problem, just be ready to turn the patients. This is a young female who had a very nice digital subtraction myelogram in the prone position, showing us no evidence of a leak into the SLEC or into the spinal longitudinal collection. So with this patient, we even checked inferiorly, didn't see it. We just rotate the patient with the needle still into the left lateral decubitus, and do another injection of about another 3 or 4 cc's of contrast material, and you can see the type 2 leak is starting to pool here. With a little bit more watching, you can see that the contrast material gets out of that herniated arachnoid and actually has a tear, and it starts getting into the epidural space and traveling north within the spinal canal. And always look for this contrast material to cross the intervertebral disc level. That tells you that's where your leak is. That tells you that's in the epidural space. Sometimes you're not sure what you're looking at because of subtraction artifacts. You go back to the original non-subtracted imaging and look for that contrast material to cross the disc space. It's very helpful. So let's talk about the other animal, the DSM, digital subtraction myelogram for a type 3, a CSF to venous fistula. This requires a different strategy, a different mindset. What you're trying to do here is find that siphoning leak that's coming out of the thecal sac along the root sleeve and somehow getting into the epidural, or sorry, the paravertebral venous plexus. To do this, we lay the patient in the lateral decubitus position and inject contrast material. And our goal is to get a very thick layer of contrast material that we can then move up and down the spine. And I call it moving the puddle. We very carefully trying to keep that a tight puddle with a little bit of curvature in the spine. And as we've gone on in our myelograms over the years, we're kind of getting better and better at this and realizing this is more and more an important way to do this. And with the dynamic CT myelograms as well, you'll hear from Dr. Callan, probably doing this in a similar way. This is the useful way to keep your contrast material along that lateral gutter of the thecal sac so that it's covering the orifices of the neural foramina and bathing those root sleeves. You want it very concentrated because that'll give you the best chance to see the flickering and the small little fistulas that are coming off of it. So we've got a nice puddle here. It's in a nice position. We watch it with our ruler that we've set up, and we know where we are. We do a run for approximately 6 to 10 seconds and move on. We go to the next level, and here's the next level up. We do another imaging of the mid-thoracic region. We move up to do the upper thoracic region and the cervical region. Don't let the contrast material dump into the head. Keep the head tilted up on sponges and bolsters. And you image the entire spinal canal that way. At the end of it, we get the patients up on their elbow, head towards the ceiling, and get the contrast material down into the lower sacral region to look for sacral tears and even fistulas. So it's easy when they look like this. This is a nice big fistula. It's filling nicely. You're basically done and you've shown it. Not all of them look like that. Actually, very few of them look like that. Most of them look like this, and this is what you got to look out for. The winking, the blinking, the wiggling, the flickering, whatever you want to call it, that's what you're looking for to diagnose these things. And there is a fistula on this examination, very tough to see, up at 30,000 feet, I say. So magnify the image. We don't have to redo a run and magnify. This is actually just when you're looking at it after the patient's done and gone to CT. Sit down and look at every level and make sure you've satisfied yourself that you've interrogated it. This fistula is right here. You can see it flickering as we go through the videos. That's what you're looking for, winking, flickering, blinking, whatever you want to call it, you're looking for that. Some of them are very subtle, some are difficult. You're not looking for the diverticular. That just fills and stays filled. You're looking for this. It's being carried away. And now you can understand why you want a lot of contrast here, very dense contrast, fully covering that orifice, because that's your best chance of seeing it down here when it's getting mixed with other unopacified blood inside the venous plexus and then carried away. This is your chance to see it. Another example of it, again, 30,000 feet. Is there a video with this? No. Sorry, here it is here. There's a fistula right here. That's it right there. When you do the magnified view and you look for it, you can see it flickering and fluttering there. Now it's obvious, but because you've given yourself a chance to see it, and here it is linearly going away. Again, every time we do it, we do a post-myelogram CT. It's not dynamic, it's just done within 20 minutes. And you can see this is a nice example of a fistula on CT coming off of the lateral aspect of the neural foramen, getting into this paravertebral vein and getting into the azygous system. Get that maybe 20% of the time, we'll get some evidence. 20, 30% of the time, we'll see that evidence on just the post-myelogram CT. Another thing we've reported on, many other people have reported on it, that the kidneys will help you, especially if you're looking for spinal CSF to venous fistulas. These are all done within about 20 minutes. Remember, the disease, the lesion, the non-physiologic thing that's happening is that the contrast is getting into the venous system. Once that contrast is in the venous system, it gets to the kidneys, both kidneys. The renal collecting system is concentrated, full of concentrated contrast material. So you'll get this number of over 100 Hounsfield units commonly on the side that has the leak. So always look for that as well. It's helpful, confirms it. So let's talk about myelogram quality, another problems we've had. Why is this myelogram not great? It's, you know, this was a good patient. We positioned the patient well. The puddle, it looks really lousy. Why is that puddle out? It's very dilute. And it just didn't work out well in that one. Here's another example of it. Really good positioning, optimal patient, very cooperative, thin, and nice positioning, but the contrast material, the puddle is not that dense. It's barely visible. So what are the things that really affect that? Our goal is a highly dense, thick, and uniform puddle, and we want to move it up and down the spine as we want. It's always nice to start with something that looks like that. What are the things that you can do for that? Well, the fixed variables you can't do much about. Your suite, your equipment, that's what you have to use. Hopefully it's good. The patient body habitus, the size. Some patients have scoliosis and flexibility problems. You're doing the best you can, but you know those things you can't really affect. Things you can affect are patient positioning. Again, very important. If it takes 45 minutes to do one of these myelograms, 40 minutes of it is basically setting up and making sure you have the right position. Needles, this is where I wanted a picture of Ian Carroll. And sorry, Ian, but he's right here if you want to see what he looks like. Ian talks about needles, and he's always recommending to us not to use this type of needle. He likes this type of needle, the Whittaker side hole needle. He even likes it if we use small needles. If you're going to use a Whittaker needle, one of the questions we would have is, what position should that be in the spinal canal? 12 o'clock, 3 o'clock? You're going to rotate that side hole to which position? That might be affecting the quality of my myelogram. The gauge of the needle, 22, 25. Now there's even 27. How does that affect the quality? And injection rate, that's a very important thing. Are we injecting at 1 per second? All the literature you're going to see talks about injecting at about 1 per second, 1 ml per second. Some people say, well, I do a 0.5 ml per second. Some recent literature will tell you, no, you really got to inject fast, because if you inject quickly, it pressurizes the thecal sac, and you get all your contrast material pressurizing the thecal sac, and that's how you're going to see the fistula, because it'll squirt out. So we took a look at this, and what can we do to make our myelogram better, make that puddle thicker and better? One of our residents, Anahita Malveya, and Emily Chung, one of our research technologists, got together and we put together a phantom. We built this little phantom out of a tube and an extension tubing, and there's the needle. And we tilted a little bit just to simulate the thecal sac, filled it with saline, and injected 300, Omnipaque 300 contrast material. We injected 5 cc's at each time. So they did over 100 injections, comparing needles and gauge of needles, et cetera, 22 gauge, 25 gauge, Whittakers, Quinkies. and different injection rates. And what we found is this is what it looks like when you inject at 1 cc per second, like everybody tells you to do it, through a 22 gauge needle. This is not the picture you want. If I go to the next slide, you can see this is the unsubtracted picture. This is all dilute contrast up here. This is the dense contrast layer, but what we want is this hyperdense layer down here. This is optimal. And if we play that, can you play that video on the top again? And just freeze it when you see the burst. Keep going. Yeah, that's the burst. Freeze it there. This is when the injection is actually at 1 cc per second. So that's the turbulence you're creating. That's the explosion you're creating. There's no way you're going to have a nice, dense, beautiful beautiful puddle if that's how you're going to inject your contrast. So it's pretty cool that, you know, a little quick experiment can help you figure this out. Positioning, by the way, makes no difference. Doesn't matter whether this side hole is aimed at the top or the bottom. You still end up with this type of dilute layer on top of the layer, the thicker layer that you're looking for, the denser layer you're looking for. Injection rate trumps everything, okay? And what we found is that you need to inject really slowly, 0.1 mLs per second or slower. If you inject at 0.2 ml seconds, you still get a lot of turbulence and mixing. And this is an example of an injection rate. Can you play the video on that for me? Thanks. 0.1 mLs per second. So it'll take you about 2 minutes, 2 full minutes to inject at this rate, 10 cc's or 12 cc's. But you get that really beautiful, dense, thick layer of concentrated contrast material to flood your fistulas so you'll be able to see them better. And you got to do it really slowly. Takes at least 2 minutes of an injection, and that's why I think Ian Carroll's happy now, because there's no reason, if you're looking for a fistula, there's no reason not to use a 27 gauge needle and just inject really slowly, even if it takes 3 to 4 minutes.
I am happy.
Good to hear it. What's nice about these 27 gauge needles is that you can even use them coaxially through a 22 gauge needle, a simple needle. So it really is worth doing that to improve your contrast puddle. So we talked about all these things. I'm just going to go through it quickly and get out of the way. Bottom line is create the puddle and move the puddle, and you're looking for the CSF to venous fistulas. In the future, this is what's coming at us. We actually have one of these rooms being installed at Toronto Western now. This is a combination of a CT scanner, the latest CT scanner, not a photon counting CT scanner yet, but this is a very good quality scanner on rails inside a room that also has the angio table with a good imaging intensifier, a coupling system. So we can tilt this table, do whatever we want, and we are now probably going to combine the two of these. So I'll leave it there. Thanks very much for your attention.